Hello, my name is RCORP and I'm the project manager for the National Consortium of Telehealth Resource Centers. Welcome to the latest presentation in the NCTRC webinar series. Today's session is on virtual support systems, the impact of telehealth on SUD, OUD prevention, treatment, and recovery. This webinar is being hosted by the Upper Midwest Telehealth Resource Center. These webinars are designed to provide timely information and demonstrations to support and guide the development of your telehealth programs. Just to provide a little background on the consortium, located throughout the country, there are 12 regional telehealth resource centers and 2 national, one focused on telehealth policy and the other on telehealth technology assessment. Each serve as focal points for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. A few tips before we get started today. Your audio has been muted. Please use the Q&A function of the Zoom platform to ask questions. Questions will be answered at the end of the presentation. Please only use the chat for communicating issues with technology or communication access issues. Please refrain using chat to ask questions or make comments. Please also note that closed captioning is available and that is located at the bottom of your screen. Today's webinar is also being recorded and you will be able to access today's and past webinars on the NCTRC YouTube channel and the NCTRC website at telehealthresourcecenter.org. With that, I will pass it over to Luke Wortley, Program Director for the Upper Midwest Telehealth Resource Center.
Thanks so much, Aria. We're pleased to have a stellar set of guests here presenting with us today for our topic of virtual support systems, the impact of telehealth on substance use disorder and opioid use disorder prevention, treatment, and recovery. I will first begin by introducing my colleague here at the Indiana Rural Health Association, Dr. Amnah Anwar. She is a senior director and epidemiologist here on staff and has worked extensively not only with the Upper Midwest Telehealth Resource Center, but in prevention, treatment, and recovery efforts through a variety of funding mechanisms throughout the state of Indiana, and has served on so many resourceful committees. And we're so lucky to have her as a senior director here. Next, we have Dr. Ryan Sarver. Dr. Ryan Sarver is somebody who I've had the pleasure of knowing over the past about half decade or so. He graduated with his medical degree from American University of the Caribbean and has worked in the substance use disorder space for some time now, has extensive experience in serving rural and medically underserved communities, not only as a family physician and an addictionist, but also as a staunch advocate for mental health and medication for opioid use disorder treatment. And then finally, we also have Dr. Errin Weisman, Doctor of Osteopathic Medicine, that she received from Kansas City University. I also know from seeing other programming from Dr. Weisman that she's a staunch advocate for preventing clinician burnout, as well as being a tremendous advocate for patient rights and all sorts of amazing work that she's doing throughout the region. So I will go ahead and hand it off to this wonderful panel.
Thank you so much, Luke, for those wonderful introductions. And thank you so much for our panelists to willing to participate in today's presentation. So we're going to start off with our disclaimer that we have to give in the beginning of all of our presentations. This presentation is made possible under the funding through the Health Resources and Services Administration, and the grant number is represented. And this program is funded to provide technical assistance to the telehealth community within 4 states: Indiana, Ohio, Michigan, and Illinois. Next slide. As Luke already provided the introduction to all of us, I'm not going to waste any more time doing that. I think that our presenters today have a tremendous experience in providing the substance use disorder, opioid use disorder treatment in the underserved and rural communities in Indiana and other states as well. Next slide. So the objectives of today's panel presentation is basically to evaluate how telehealth has expanded access to substance use disorder. Special focus has been on the opioid use disorder services, particularly in the remote and underserved areas. We will discuss the recent policy and regulatory changes affecting telehealth delivery to substance use disorder and their implications. We will also analyze the management of complex SUD, OUD cases in telehealth, including challenges and effective strategies. And at the end, we'll also discuss the recent technological innovations in telehealth that enhance the prevention, treatment, and recovery when it comes to substance use disorder in rural areas specifically. Next slide. So I'm going to hand it off to Dr. Sarver. I've had the privilege of working with him on a program when he was still in Indiana, in Southern Indiana. That was the Rural Communities Opioid Response Program. At that time, wasn't a very long time ago, but he was the only MOUD champion that we had within our consortium that we had, and staunch advocate for the medications for opioid use disorder and various different modalities to provide that treatment to the people in rural Indiana. So Dr. Sarver, take it away.
All right, thanks so much for having me. I have no relevant financial disclosures. You can go ahead and go to the next slide. All right, so we've been tasked today with a couple of items here. The first one is to evaluate how telehealth has expanded access to both substance use disorder and opiate use disorder services, particularly for remote and underserved areas. Next slide. So really next slide, thank you. So really what we're looking to do with telehealth, and the primary goal is to overcome barriers to care, really to establish what's considered a low threshold MOUD clinic. This is a concept that analyzes barriers, whether those are socioeconomic barriers, different social determinants of health barriers, access, transportation, all of these things that get in the way of a patient really being able to get into treatment. Telehealth can tackle many of those. Next slide, please. So we're talking about social determinants of health. I'm sure many people in the audience are aware of what this term means, but I'll go ahead and go through an overview. So that's really taking into account a patient's background. So their education background, what is their level of education? What is their reading comprehension? Do they have access to quality health information? Do they have access to quality health care? In many rural areas, the only access to healthcare is going to be many, many miles away. And they may not have reliable transportation. Many patients who are affected by opioid use disorder and substance use disorders also have poor social resources. Many people in the throes of active chaotic addiction will burn through relationships and seeking out their drug of choice. And so many of them don't have the same social networks that somebody who's not in active chaotic addiction would have. They don't have access to reliable transportation. They may not have funds to purchase a car. They may not have funds to, hire an Uber. When you live in a rural area, you don't necessarily have Ubers. They just don't exist. And so what we really need to do is figure out how to get access to these patients. Most patients have access to a smartphone. And so they can get on to different telehealth modalities. For many practitioners, there are, and those in rural health clinics, there are actually free telehealth resources such as Doximity, which doesn't cost anything to sign up for. And you can send a link to these patients and they can have access to that clinician, so that clinician can then prescribe life-saving medications without having to worry about having a robust case management team that's going to get transportation, that's going to get a Medicab, that's going to get them bus tokens or whatever other modality to get them into the clinic. So that's really where telehealth is going to come into to help out overcoming those barriers to care. Next slide. So what I recommend for anybody who's looking into figuring out how to implement telehealth or how to overcome these barriers to care is figuring out what your case management resources are. So if you don't already have case management, you should talk to your healthcare administration and have somebody who can coordinate with these patients. Oftentimes that starts with a peer recovery specialist. And a peer recovery specialist can reach out to these patients via phone A peer recovery specialist, first of all, if you're not familiar with that term, is somebody with lived experience. So they are somebody who is in sustained recovery from addiction. Sustained recovery is longer than a year, who then goes through a rigorous training program to become somebody who has case management abilities and skills, who can then connect patients to community resources, whether that's triaging them to the appropriate level of outpatient care, whether an intensive outpatient treatment program, an opioid treatment program, colloquially known as a methadone clinic, or a detox or rehab center. That peer recovery support specialist can contact the patient via phone if they don't have ready access in person, or also through a telehealth visit. So they can open up a video chat and check on the patient, see if they have access to their medication, have access to harm reduction resources such as naloxone, and have access to transportation, and if not, can arrange for transportation. Sometimes that's not feasible in rural areas either, having the resources for a peer recovery specialist. In which case, just being able to pick up the phone and get into an app like Doximity and bring that patient up on video becomes a life-saving modality where you can prescribe this medication to the patient, to their local pharmacy, and they can pick it up, and they'll no longer be looking for their medication of choice or drug of choice on the street. A couple of other resources, if patients don't have a smartphone, which most do, perhaps they are actively homeless, or they are lost or had their phone stolen. Many public libraries also have private computers that can be used in a private room where you can have a telehealth visit. So that's another resource that you can consider. I would also consider putting together a community resource list if one isn't already available through your case management team. That you can hand out to patients, or if you have a peer recovery support specialist or looking to develop that team, they can put together that resource list to help patients find how to overcome those barriers to care. Next slide, please. So now I want to talk a little bit about the policy changes that have happened since 2008 and the Ryan-Haight Act to the CARES Act in 2020, which occurred during the COVID-19 pandemic, which reduced some of the barriers to telehealth and providing MOUD medications. Next slide, please. So in the CARES Act, which is the Coronavirus Aid, Relief, and Economic Security Act, it used to be that you had to have an in-person visit first in order to prescribe buprenorphine, so Schedule 2 through 5 medications. Some of those were relaxed to where you can actually institute medications for opiate use disorder over video. And in fact, if you work in an opioid treatment program, an OTP or methadone clinic, you can actually prescribe buprenorphine just over a phone call. So, and those requirements of an in-person visit were laxed during the coronavirus pandemic, and that was set to expire last year. That was renewed for another year, so, and that goes through December 31st of this year. So we're waiting with bated breath to see if they're going to continue those rules and allow us to continue to provide these life-saving medications through telehealth. Fingers crossed they will, because we have the data it is in, and access to telehealth for prescribing buprenorphine saves lives. Next line, or next slide. So there are many articles out there. I put this one out there from the American Medical Association that really shows that that having access to buprenorphine through telehealth reduces patients seeking out medication on the street, which for those of you who work in the addiction space, everything out there, whether it's heroin or pressed pills that they get off the street, they think it's a prescription, it's not. All the pressed pills out there are either fentanyl or a mixture of fentanyl and xylazine, which is actually a animal tranquilizer that Narcan doesn't work on. So it's really up to us to advocate for our patients and find resources for them to get these medications into their hands. When patients go to the street and they don't have access to harm reduction strategies such as, ready Narcan, and they don't have access to buprenorphine, there's really no way for them to overcome their addiction and be helped out of that without us coming and meeting them. And that's really where the expanded access to telehealth is going to help out and really going to save lives. Next slide, or next slide. I want to talk a little bit about what the White House is doing for their, they actually just put out a bulletin that they are working on several points to expand access to MOUD services. I did put a little link when you send out these slides that you can review this policy statement that the White House has put out for yourself and the expansion of MOUD services. Next slide. So in order to reduce barriers and hurdles to care, they are going to hopefully, this is, right now it's not permanent, but they're hoping to make the COVID-19 era flexibilities for telehealth. They're hoping to make that permanent for many different aspects. One of them is if you work in an OTP, patients can receive take-home doses of methadone, so longer take-home doses. If you're familiar with this, oftentimes patients will have to go get their methadone every day, and that's just not feasible for many patients. Eventually they get take homes for a week at a time, 2 weeks at a time, up to a month at a time. So those rules under COVID-19 relaxed, and they're hoping to make that permanent. For telehealth, what I was speaking of before, methadone can actually be prescribed via video and audio, and buprenorphine only over the phone, which is very convenient if you're an OTP. If you're not an OTP, you still can, and you're a DEA licensed practitioner. So that's whether you're a physician, a nurse practitioner, or a physician associate, you can prescribe buprenorphine over telehealth. So that you don't have to have that in-person visit anymore, especially if you're going to continue it, something that's already prescribed. For some of the barriers for entry into a treatment program, this is for into either detox programs or through an OTP. They don't have to have a long history of addiction before they're eligible to go into those treatment programs. So if you have a patient who's in active chaotic addiction and you triage them and determine that they're not safe for outpatient treatment, especially in a rural clinic where you maybe don't have the same amount of resources, maybe the rules for getting them into a detox are a little bit lax there. And then really just expanding access to medication treatment while awaiting further services. The goal is reduction in barriers to care. Next slide, please. Some of you may be aware that several years ago, the requirement for an X waiver to prescribe buprenorphine was lifted. For those of you who don't know what the X waiver was, anybody who had a DEA license prior to, I believe it was 2021, was required to get 8 hours if you're a physician, so that's MD or DO. You're required to have an 8-hour training program in order to prescribe buprenorphine. If you're a nurse practitioner or a physician associate, you had to do 24 hours of training in order to prescribe buprenorphine. That requirement for the X waiver was lifted. And so now, if you hold a DEA license, you can prescribe buprenorphine out of your clinic. And in fact, if you're in primary care, you should be prescribing buprenorphine for your patients. Addiction is a chronic relapsing disease of the brain, no different than diabetes or heart disease, and we should be treating this. And now if you are treating out of a rural clinic and you're in primary care, you more than likely have a DEA license, and so you can start prescribing buprenorphine. So the Biden administration in 2021 lifted the X waiver, and now in order to renew your DEA, you have to do 8 hours of training. So basically, they made everybody who's going to get a DEA license renewal get the training that you would need for an X waiver. So now everybody can prescribe, and that includes over telehealth. Next slide. And then the last thing that they mandated is increased access to harm reduction. And so those are naloxone kits. So this is especially important in rural areas. There are many networks out there that are involved in harm reduction and getting Narcan into people's hands. One of the major things that the government did was remove the need for a prescription for Narcan. So, or naloxone is the generic name for Narcan. Naloxone can now be obtained without a prescription. However, it's often cost prohibitive. So a lot of patients can't afford the often $40 to $50 per dose of this life-saving medication. And so there are many grant programs out there that you can get naloxone vending machines or things called nalox boxes, which will sit outside of your clinic. And there are organizations who can come and fill that with Narcan, or you can get free Narcan to fill it. So I would look into that. And anytime that you see a patient via telehealth for buprenorphine, you should also be sending a Narcan, so they'll have that with them. Next slide, please. So really the take home here is finally government is waking up and realizing that the only way that we're going to tackle the opioid epidemic is through sustained efforts in reducing barriers to care and increasing access to harm reduction strategies, such as more take-home doses of methadone, increased access to buprenorphine, and free access to Narcan. And a lot of that is going to be facilitated by increasing any access to our patients that we can get, to where we don't put barriers where they have to go to an opiate treatment program or a methadone clinic, or they have to go to the hospital, or they have to see an addictionist. They should be able to go to their local healthcare clinic, their local family practitioner or general practitioner, who can then prescribe buprenorphine and naloxone and ultimately save their life. Thank you.
Thank you so much, Dr. Sarver, for going over the policy and the legislative issues. There was a question in the Q&A, which I believe Dr. Weisman has already answered. Just a reminder that there will be time for question and answers at the end of the presentation after we've had some panel discussion. Now I'm going to hand it over to Dr. Weisman, who is going to talk a little bit about the provider-focused issues with access and accessibility for the substance use disorder treatments via telehealth and other modalities, and then also provide a little bit of information of her work in rural Indiana that she's doing. Dr. Weisman?
Yeah, thank you so much. It's great to be with you all today. Please use the Q&A box. As you can tell, I love to answer questions. I call it the chitty chat box. So pop them in there, even if it's just a question that's just adjacent to what we're talking about. I think this is a great forum and a lot of great people here who can provide some really good answers. So let's pop over to the next slide. I am Dr. Errin Weisman. I am in Southwestern Indiana. I practice addiction medicine and primary care in an FQHC setting. My facts are Indiana focused just because that's where I'm at. So if you want to grab your state's information, I have a resource page at the end that you can get on there and look at SAMHSA's website, the National Institute of Drug Abuse, at the most updated data for the area of the country that you're in. So right now, Indiana ranks 14th nationally in overdose deaths, and this is from 2020 data, and we're still waiting to populate and see. We know we had significant increases during COVID period. People went without medications, mental health worsened, supplies changed. And so unfortunately, I'm afraid Indiana will probably stay the same, if not get a little bit worse. In these numbers, you want to be at the bottom when it comes to ranking and overdose deaths. Interesting enough, as we've started to go into more rural areas than the cornfields around me, we are also seeing Indiana youth upwards to 12.5% that are using substances. And unfortunately, Indiana ranks in the lower third of being able to provide behavioral health services to individuals who are suffering with addiction. So for anybody who's out there doing this type of work, I am sitting in the middle of these statistics right now. The city that I work in has the Walmart, so you know it's a big deal. But other than that, I live in a county that has more livestock than people. And so this has been super interesting work for me. I am originally from Southwestern Indiana. I used to tell people that I love talking about drugs. Indianapolis houses one of the DEA's headquarters, and I would go up quarterly. I got interested in it as a student to listen to their presentations. And it was just something that always tend to just be an interest. And when I was training in the early 2000s, it was like, no, you don't want to get that X waiver because then you have to take care of those type of people. Or you're a young physician, you need to establish a strong practice before you have those kind of people come in. And what I realized very, very quickly within the first month of practice outside of residency, that those people are my people and they're my neighbors and they're the people I go to church with, I see at the library, the grocery store. They're my kids' friends' parents. It's everywhere in rural Indiana. So many blue collar workers. We're down here with a bunch of coal mines. Injuries happen, heavy labor, farmers. They got started on opiate type medications, and it just kept growing from there. Then we locked down with the different opiate laws, our prescribing methods, inspect, all of that changed how our prescribing methods happened. And folks who were used to getting their pain medications on a regular basis no longer had that and had to find other sources. And it's so interesting now when I sit down and talk with patients to understand their journey and where that came from. I have women who tell me, yeah, I got started on Percocet when I was a teenager because I had really bad periods. The first time that I used was with my mom. She used to pay me in pills that I could sell to other kids, but I tried them and decided that I didn't want to use those as my allowance, that I just wanted to keep them for myself. Just incredible stories that you hear about growing up, middle income, country girl. It's just very different from my own life experience. But yeah, I'm so intrigued and I love serving this population. I've been in medicine out in practice a little over 10 years now, and it's been super interesting to continue to serve in my rural communities to see how much has changed is also how much has stayed the same as well. And so I'll be giving a little bit of perspective of like the boots on the ground, where Dr. Sarver was giving us a lot of statistics and updates. I'm so glad he did that. I am not a data nerd. I would much rather tell real life stories. So go to the next slide and we'll start getting into a little bit about that. So Dr. Sarver mentioned this. I call it the 3 A's. So is there the availability for treatment? Is there the accessibility for treatment? And is there the acceptability? And actually the last A, I think is the one that on a continuous basis when I'm out in the community that I'm talking about. Head to that next slide. So when I'm talking about availability, I'm talking about on the provider side and what barriers that you and I come in contact to. This was off of a couple different studies, again, that's in the resources. But when providers, physicians, nurse practitioners, PAs, all the like who are prescribers were asked, you know, what are your barriers to care and what are the issues for prescribing MOUD? These were the top answers. Providers lack of time, lack of office space, and trained staff. They felt like the lack of specialty backup wasn't there. Some of them said that there was a lack of patient need. I'd have to push back on those folks a little bit, you know, because if you don't ask, you don't know. Resistance of partners and leadership, a lack of confidence, DEA concerns, the attraction of drug users to their practice, regulations, attitudes, beliefs, and perceptions regarding buprenorphine and the intention of utilizing it. And then also the lack of mental health services was really concerning to a lot of providers. Many times when I'm talking to colleagues, I have to address each one of those. And what I say is, if you have prescribed Norco in the past, if you have prescribed any kind of benzodiazepine, you can prescribe buprenorphine. And let me tell you how the profile is so that you can feel more confident with it. Now, of course, there is a time and place to send anybody to a specialist. But if you work in a rural area like I do, right now it's about a 14-month wait to get into a rheumatologist. It's a little over a 10-month wait to see a neurologist. And, you know, there's just so many specialties I want to get my people into, but I end up being their specialist. But what I would encourage folks when you're thinking about taking care of folks with substance use disorder is that they don't evidently need to go see a fellowship trained addiction physician. These are things that you can get started by just having really open and honest conversations, going into the patient visit with curiosity, like, hey, instead of saying what's wrong with you, you today, asking, what's happened in your life? Or one of my favorite questions when I go and meet a new patient is, tell me about your relationship to whatever substance maybe they mentioned to the nurse. Tell me about that. Like, where did it show up in your life? And then I just let the patient talk. And I have collected so many incredible stories. One day I'm going to write them all down for everybody to read, of course, HIPAA compliant. But people show up in our office, and when we are willing to sit back and just close our mouth and listen, they will tell you what's going on. And the great thing is we have the data and the evidence that shows that MOUD is safe and effective for our patients. I mean, what other medications can we say, I am going to give you this medicine, and I can tell you with data supporting it that I can protect you from dying? You know, of course, statins for MIs. We now treat people and cure their hepatitis. So it's a great time to be in medicine right now and to provide these medications and really see big changes in people's lives. Because I see when we use these medications, it just calms those areas of the brain down for folks so that they then can, look at their social determinants of health. And what I tell them is, I want to help you live a nice, boring life. No more legal involvement, no more running from debt collectors. I really want to help you so you can go on a Florida vacation when you want to and not have to sit back and be in a state because you've got legal troubles and can't go, or not have the finances to be able to go. I recently started helping a couple who come in and see me. They really want to buy their own home, but we were just so overwhelmed. They didn't even understand where to go. And I said, hey, I've got a great resource. The USDA is really promoting home ownership in rural areas. Let me get in contact with our local USDA office, and they're going to be great before you even go talk to a bank. Because so many patients really have had trauma with our everyday life. Walking into an ER, into a physician's office, the bias that maybe has been poured upon them. These folks were scared to go into a bank. What are people going to think about me? Are they going to run a background check on me? Am I going to be able to qualify for a loan? So I love this work. One, because I tell everybody the medicine's not the hard part. It's helping with everything else, but just being invested in people's lives. So that's the availability piece. And so I would challenge you to say, are there anything on this list that you're sitting back and like, that one gets me a little bit? If so, put it in the Q&A and I'd love to talk about it more. Hit me with the next slide. All right, this one should say patient-focused barriers to care. Sorry, my little typo, but accessibility. So this is what we're really getting at in today's webinar. The distance to a clinic or treatment center. So right now, for where I sit in the city that has the Walmart and the Applebee's, that's another big thing in rural areas. Where's the Dairy Queen and the sit-down restaurants? It is over an hour drive to any OTP, so any place where someone can access treatment with methadone. And Indiana is one of the most restrictive states when it comes to methadone treatment. The federal government is more liberal than we are here. So here in Indiana, people aren't able to get to those monthly take homes till far, far into their treatment because of state law. And so many of my patients are driving at least an hour there and at least an hour home every single day for weeks to months on end. And it's just not conducive with life. I've got 3 kids at home. I got to get people up. I got to get Pop-Tarts in them. I got to get them to school, right? And if I have to start my day 2 to 3 hours earlier than that, my kids would be beasts. Absolutely. So I think we really have to focus on that. And I know there are some creative solutions with doing satellite centers with OTPs, and I'm really excited to see that here in my state as well. Again, in rural areas, we have the lowest ratio of population to providers, and that's both in primary care and psychiatric care. So for them to actually see a qualified individual, they're less likely to get to them because there's less of me's and my colleagues around. Another concern is the ability to pay. We have centers that provide buprenorphine in our area, but they don't take insurance. They don't take Medicaid. They don't take private insurance. It's all cash-based pay. And so that is a big barrier for folks when folks are living what we call very close to the earth to make sure that they get those appointments so that they can get their medication. There is a lack of insurance coverage, or they don't have insurance at all, either because they're working poor and they cannot afford the insurance premium that's provided through their work, because many businesses in rural areas are small businesses, single owner owned businesses as well. And so the ownership cannot provide those type of insurance coverages. They go to the marketplace and they say, Doc, I can't even afford that either. And so it is a big challenge when maybe we're talking about doing like injectable buprenorphine. They're not going to be able to afford that without some kind of coverage. Transportation. Dr. Sarver mentions before, there's no Uber or Lyft here. There is your friend, your mom, your grandma, your cousin's best friend, the girl you dated in high school, those kind of folks that are you call on favors to get help from. And then even if you get a ride, maybe the ride's not super dependable and it's raining outside like it has been for the last couple weeks, and the car won't start. It's a huge issue, transportation. We sometimes have I've had people ride bikes over 8 miles to a clinic. I've had them come in horseback. One guy brought a mule in a cart one time. All sorts of different ways, hitchhiking to try to get to the clinic to see us. People are so ingenious and they figure it out, but also why do we have those barriers that we put in place that people have to figure it out? Another big one is childcare. Moms, parents, fathers can't get away. Even, in rural areas, there's a significant increase of grandparents taking care of children as well, grandchildren. And so that also leads to some challenges, because do you really want your kid to sit in a room when you're talking about your substance use? Maybe if they're a little bit older and they can comprehend and understand what's going on, but that's not always the case. There is lots of times where they say, hey, I'm sorry, Dr. Weisman, I had to bring my kids. I get it. We keep books around, we keep little gadgets, toys, coloring books, that sort of thing to try to keep them entertained, but it's not the best ideal situation. There's limited time for our patients and competing priorities. They're maybe working their second or third job and just trying to make it in life, and let alone try to get to an appointment that's at 11:30 in the middle of the day, right? They've worked a night shift, they're trying to sleep, they're going to get up at 1, go work another job, and then go back to their night's job. And the other thing is the inability to miss work. Again, talking about employment is so important for people's health, and the potential to no longer have employment is very scary for a lot of our patients. Next slide. The last thing we butt up against a lot of times, and this is something that I'm super passionate, is going in and talking to community members, key members, law enforcement, teachers, schools, probation officers, churches. That's been a big one. Church is a big deal in rural and underserved areas. Just talking about, like, what do you think about medicines to help folks with substance use disorder? What do you think substance use disorder is? People always have a story, and so their cousin's brother went to treatment over yonder, and he came back really goofed up. We should never send anybody to treatment. Those are the kind of stories that they live with. I know one patient on my primary care side would say, you don't go to the hospital because that's where you die. And well, if you don't take care of yourself, that is kind of a true statement, is unfortunately, but also really getting folks to understand what prevention is. There are a lot of concerns about the lack of being anonymous in a rural community. Everybody knows everybody's business, and Sunday morning prayer list, it's never a good idea to see your name on that. And also the beliefs in treatment doesn't work, or it's not needed, or you're weak if you have to accept medicine, or that you're not really in sobriety if you take medication for it. And there's also some disconnect about the distance. I'm going to tell you, rural people here in Indiana, us using these screens, they get a little nervous about it if you're not local. If you don't speak the same way that they do, they're a little leery at times. And so that trust building takes a little bit. All right, next slide. So that's all the stuff that we are up against when you're trying to establish a new type of practice in an area that is underserved and rural, at least from my perspective. And so one of the great things, I've been working with the Indiana Rural Health Association. My organization is called LifeSpring Health Systems. We were able to partner with them to get a grant that Amnah mentioned early on. And we are serving Orange, Crawford, Harrison, Perry, and Spencer County. So you can see the little stars down there. It's quite a good distance from Paoli, Indiana, down to Rockport in Perry County, or Spencer County, excuse me. You're talking over 90 minutes to get from place to place. And the same thing over to Corydon and Harrison County. So we cover a little bit of distance. The grant we're doing is trying to get medications and substance use awareness and treatment into these 5 counties. How we've structured ours is we have a LifeSpring office in each of those 5 areas. Some of them are no bigger than a house that's been converted. For instance, in English, Indiana and Crawford. Some of them are a little bit bigger, like our Paoli office, but most of our offices there have a therapist. They also have case managers. They've been seeing patients, but they haven't had the medical side of substance use disorder treatment. And so our structure is we have a medical student, our medical assistant, her name is Stephanie. She's wonderful. She drives to each of these locations 1 day a week. And then me and my nurse practitioner, Kayla, who's also on this call today. Thanks for being here, Kayla. We telemed into those locations. Does it always work that way? No, not always. Patients don't always come to that centralized location. We try to get them there because then we feel like it helps them establish a small little community where they can get the social supports, they can get the counseling, the group, the medications with us. We can help meet any other needs that maybe they have going on. Case managers can transport them from home to the office. But at times, it just doesn't work. So we do have to do telemedicine to their smartphone, or worst case scenario, but you know what? It's the best visit we can do. We'll do a phone call and talk. How are you doing? Checking in with them. What do you know since we talked last? How have your cravings been? Tell me a little bit more on the slip up that you mentioned. And we go by the policy, honesty over perfection. We truly believe in harm reduction. We're not there to be the justice system. We're really there to offer them options. And in our first 5 months that we've been here, I underestimated the need that will be. So I'm in DuBois County, Jasper, Indiana. It is just left of the line of stars. A lot of my folks come in, they are justice referred, or they've talked to somebody who have been my patient and said, hey, such and such told me to come talk to Weisman. Great. We get in there, we see them. We have some polysubstance use. It's typically with alcohol. It's a very German Catholic county. But what we found going into these other counties is I truly feel like at times I have stepped into Appalachia country. We're talking about people who do not have running water in their homes. They're heating with multiple sources. It could be a coal stove, fire stove. They don't have air conditioning. Like I said, they ride their mule into town. It's been really interesting to try to navigate that and understand the different communities. One things we did early on in this process was actually getting in the community, talking to pharmacists, because it seems like every area has a CVS. So getting into CVS and talking to those pharmacists, seeing what their perceptions are, trying to have an open discussion and say, hey, this is what we're doing and this is our practice and here's our number. Please call us anytime. And getting pharmacists on our side has been really, really helpful to help our patients as well. There's still a lot of pain clinics in the area. And so at times, I wouldn't say that we butt up against them, but trying to have patients understand that you really need to think about your pain management plan if we're talking about starting naloxone, buprenorphine, something like that. And how we can treat their pain maybe differently than with Lortab, hydrocodone, oxycodone, that sort of thing. The other thing is we have caught into some just really high polysubstance situations in helping folks navigate SUD. I'm so thankful that I went through a clinical fellowship in addiction medicine the last couple of years to help navigate during this project, because it can be absolutely overwhelming when someone sits down and starts talking about what they're putting into their body or what they would like to put into their body, but that they're using instead. We've also got really honed into doing home inductions and having a lot of harm reduction conversations. Next slide for me. So with the few minutes I have, and you guys in the panel can cut me off so that we can do Q&A, I just want to share a little bit about, and these are change for HIPAA compliance. These are a few of our patients that we've had just in the last couple months. So Sammy Joe is a 16-year-old male. He started using THC and stealing opiate pills from his grandma at 14. He's in trouble with school and tells me I can't go back until I'm clean. His high school actually does do urine drug testing on students, and based on that urine drug testing decides whether they can stay in school or not. He has been admitted into the big town of I can't remember if it was Indy or Bloomington for a mental health stay. He did IOP, and he presents because his therapist in one of our offices said, "Hey, why don't you go see Dr. Weisman and see if she can help with any of your medications." When I got this young gentleman into my office, his mom came with him, and his mom broke down in the office and told me about how many of their family members have overdosed and died, and that those who hadn't died were on the Suboxone, and that she didn't really want Sammy Joe to be on the Suboxone, but she doesn't know what else to do. Another patient we had in a similar in the same office was Sherry Sue. She's 40-ish. She got involved in a major motor vehicle accident in which everyone in the car was intoxicated, polysubstance. The driver and the front seat passenger were dead on impact. She was in the back seat without a seatbelt on, was life flighted to, again, Indy or Louisville. She was intubated at the scene. She required ICU and very extensive treatment that first week, but was slowly, after multiple surgeries, able to be weaned back. She had bilateral tibia and humerus fractures, so that's arms and legs, and the love of her life was the front passenger seat driver. She came into me with polysubstance. Now she's got major injuries, so dealing with pain as well. And she is in the deepest, darkest grief and depression that I've seen in someone in a very long time. She's also lost her source of income, which was the love of her life. They no longer have a car because it's demolished. And she feels like family is just pulling away from her now, like she's a black cloud. Another patient we had in a different office, Smithy, 28-year-old male, he canceled his appointment on the day. I believe this was with Kayla. He was supposed to get one of our buprenorphine subcutaneous injections. But later on, his friend decides to load him up and bring him into the office because they know that's where they can get help. They get him back there. Stephanie lets Kayla know, hey, this guy does not look good. And so he appears sedated, lethargic. Stephanie tells Kayla, wow, his pupils are small. He's really pale. He's breathing, but he just doesn't look very good. And so we literally have this patient show up in our telemedicine, just a screen exam room. Sometimes I feel like I'm Dr. Quinn, medicine woman, figuring things out, but I have to say, as hard as it is, it's also a joy to take care of these folks. So with that being said, I am open to any questions, any discussion. I know any of our panelists are open to that as well.
Like Arya mentioned, if you have any questions, you can put it in the Q&A box. I had a question from both of you. I think I would just post it. If there are other questions that come up, we'll handle them. But both of you have used telehealth, because in rural, that is what we kind of like promote as a modality to overcome the barriers to access, like transportation, childcare, stigma, and all of that. But there are issues to telehealth access in rural as well. There is like broadband issues. Dr. Sarver mentioned public libraries and other resources. But how have you overcome those barriers that come with the use of telehealth? And what are some ways in which you think if somebody else wants to adopt telehealth to provide medication for opioid use disorder or other medications to treat substance use disorder and provide that prevention aspect as well? How have you done that, or what can be done?
Yeah, so I've actually, you want to go, Dr. Weisman?
It doesn't matter.
Okay, well, I'll just say experience in two different systems. Rural hospital system was a little bit more difficult when I was in Indiana, which I actually transferred over to the VA in January of this year. So previous to that, reimbursement rates for telehealth were very low. And so uptake for telehealth, I think, was a big barrier for health systems. So and currently CMS is working on that to improve reimbursement for telehealth. But I think that's probably the number one barrier on the administrative side to having telehealth really come full force and be a modality that we can just choose as akin to a face-to-face visit. I will tell you the VA is much different. It's the federal government. And so I can choose to do a telehealth visit whenever I want. And I see a lot more telehealth patients than I did in the private sector. Now, one of the things the VA is doing for those either elderly patients who are not technologically savvy, or for patients who don't have access to this technology, is they actually have somebody go out to the house with either a tablet or a laptop, which is case management, and then you can have a telehealth visit with that patient. If that's not feasible, that patient can travel to their nearest healthcare facility that's VA affiliated, and then we do a telehealth visit with technology on both ends. So and that really could be used by the private sector or other healthcare facilities where, we have, I don't know about you, Dr. Weisman, but you probably have an iPad that you use for interpretive services, right? So you're currently, I assume that's what's being used. That's what I've used at most of the rural locations where, we didn't have somebody who spoke Spanish or Haitian Creole. And so we would have this tablet that we could use, and you could do that. You could have case management go out to a patient's home and use that for telehealth. So I think we really got to get creative. There are technological solutions out there. We just got to get CMS to make them reimbursable so our administrators will find them acceptable as well.
Yeah, you do get creative. I know usually there is a library, restaurant, gas station that has Wi-Fi. And so we find those spots in each of the areas that we're at. And I will tell patients, if you can get to that parking lot, you can get on the Wi-Fi and talk to me. Just because this area of Indiana that we're in, it does get very hilly and they can't get signal down in the hollers. So that's one thing that we've done. We have the ability, kind of like Dr. Sarver was saying, to bring them into a clinic. We have a case manager. We actually have a phone designated. It sits here on my desk called the texting phone. It's literally just a work issued cell phone, and we get permission from patients to be able to text them directly. And sometimes that's all they have. They don't have any minutes left on their phone, so they can't call into the office. So we call it the texting phone, and case management can take that out to them as well and do a televisit on that. But you do get creative. I've even at times gone back to old school home visits. I'll tell folks if I'm in the local area, hey, I'm going to be at the LifeSpring English office on this Friday. If you can get here, I'll see you. We may not put them on the schedule because, if the creek rises and they can't get out, well, then that is what it is. But just trying to make that availability. And what I've really found too is if you keep making effort for people and you keep showing up for them, they will put that effort in as well. Just knowing that I'm going to bird dog them until I get a visit with them or get to see how they're doing. We are to the point at times where we'll just send a letter as well. Like, this is the phone number. When you can call us here, let us know how we can get better in touch with you. and it still works. I mean, we collect emails at registration. I think every office does. We utilize that as well. So I think it's just getting out of the mind frame of like, this is how medicine has to look, and just saying, okay, like, let's get creative here. Some of the best solutions have come from my MAs, from my team. And so it's my job to listen to them and promote those ideas for them as well.
Thank you for your response. I think we have time for one more question, and that's where I think in my work in rural Indiana and the initial pushback, and I think sometimes even now the provider pushback is that they don't really have the supporting framework to provide the substance use disorder treatment. They don't have that supporting network of other providers, or even the connection with experts that they can reach out to if they have any specific questions regarding treatment of those very complex patients. So I think my question for you would be, like, while delivering care to via telehealth, in the absence of that support and network, or even sometimes case management, what are the barriers that I wouldn't say like the barriers, but what are the ways, different solutions that you have found to be useful while reaching out to those patients and treating them just using telehealth or any other services that you just mentioned?
Yeah, so I would definitely utilize the echoes that are available. Echoes are a learning system for which folks show up specialists show up in these Zoom meetings like we're doing today, and me as a primary care doctor can show up and ask my questions and essentially get a face-to-face consult with someone. And so I would look up echoes. PCSS is a provider-sponsored portal. I think it's SAMHSA has it. It's pretty easy to get a login, and you can get in there, and folks can, if you're a provider, get questions answered. You can go back through and see all the different questions that have been answered about all the different substances. How would you approach this? I'm prescribing buprenorphine, but they're on clonazepam. What do I do? So I think those are two resources that I've utilized a lot, and I would encourage others to. Help is out there for those who ask.
There are also, ASAM has some really nice like discussion portals that you can hop on. And as a primary care provider, you can ask a question, and there's forums on there where other addiction specialists will answer those questions for you, which I think is also a great resource that I've utilized before. And then as far as like telehealth resources, like I usually promote Doximity because it's so easy to use and it's free, and it is HIPAA compliant, but I believe, a lot of them are HIPAA compliant. So I believe Teams is HIPAA compliant. So just check with your administration about what's available. Or if you're a solo practitioner, Doximity is probably the way to go. They have the ability to private text and private call your patient, so your patient doesn't get your phone number, and they can send them a link to either email or to their phone, to where they just pop right into a little video visit, much like we're doing right here. So that's a great resource.
Thank you. I think there was a question about putting some of those resources in the chat, the ASAM information and the others. So if we are not able to do that, I will get those from you, both Dr. Sarver and Dr. Weisman. There is one question that I want to get to before we run out of time. It's in the Q&A, and it asks that, do you recommend the use of an in-person visit at some point over the course of treatment when using telehealth? And if so, at what point?
I mean, an in-person visit is always going to be superior to telehealth visit. You're going to gain way more clinical information by being able to see your patient face to face, but it should never be a barrier to saving their life. So really you have to triage based on that. If all they need is buprenorphine and a Narcan, you should not mandate that you see them face to face. At some point, it will be useful in your relationship, in your therapeutic relationship, to see them face to face. But again, the number one thing is saving lives. So if that's going to be a barrier to their care, don't mandate that.
Dr. Weisman, do you have anything to add?
Yeah, my thought is, just like we're just doing Zoom today, online friends are real friends too. I think I still have meaningful patient interactions through the computer screen. I do occasionally go to those sites when I'm available to I'm a hugger, to go give them a huge hug, congratulate them, celebrate a big sobriety milestone with them. Yes, we would all love to do things in person. However, like Dr. Sarver was saying, like, this work is still very meaningful. You still get a lot of good information. You still get the trust. You build that doctor-patient relationship. And if this is the way that it needs to happen, great. Mentioned before, I do some online coaching about physician burnout. I talk to physicians all around the country. I would say that the relationship that I have with those folks are just as meaningful. So can I get a good ear exam from the computer screen? Absolutely not. And that's what I tell patients when they come in with some issues, is like, hey, this is bigger than a televisit. Like, I really need you to get someone to lay hands on you, be that urgent care, or if they're willing to make the drive into Jasper, I'll say, I will see you. If you come, I will see you. And I think that for folks, when they do come and make the drive here, I know what it takes to get them here and how much I just appreciate them doing that.
So what I'm hearing is that if telehealth is the only thing available, then it is not mandatory to have that in person, unless like it is needed for some other ailments or any other services that they need. So I hope
as of right now, yep, unless they change something, yep.
So I think we're out of time. I just put in the information for Luke. He is the program director for the Upper Midwest Telehealth Resource Center. And Arya, you can wrap it up now.
Thank you, Amnah. Just a reminder that our next webinar will be held on Wednesday, June 12th. That's been rescheduled from our regular third Thursday schedule, and it's going to be hosted by the Southwest Telehealth Resource Center. Registration information is available on the NCTRC events page. And then lastly, we do ask that you take a few short minutes to complete the survey that will pop up at the conclusion of this webinar. Your feedback is very valuable to us. Thank you again to the Upper Midwest Telehealth Resource Center for hosting today's webinar, and to Dr. Sarver and Dr. Weisman for their presentations today. Have a great day, everyone.